Welcome back to Stop Feeling Like Shit. I'm your special host, Danielle LaCourte, with Dr. Buzz, my favorite person in the world. And on today's episode, we're talking about bipolar disorder and insulin resistance. And our special guest, once again, Joe Matovich, is in the house. Welcome back, Joe.
Thanks for having me again.
Yeah. I mean, at this time, we know who Joe is. You should know who Joe is. And if you don't, you need to go back through a couple episodes or just come to Buckeye Physical Medicine and meet Joe. Joe, what's up?
What's going on? How are you guys doing today?
We're doing great. We're having a good day. So I'm excited about this episode because I feel like bipolar and disorder. And then also I'm like over here wondering like insulin resistance, how does that go together? So I'm excited for you to tell us about that stuff. So we're going to get started and I want you to tell us, what is bipolar disorder?
So, it's interesting we're getting into this now because it seems like the diagnosis of psychological disease and disorders has gotten exponentially higher over the last few years. Bipolar has two different iterations, type 1 and type 2. Both type 1 and type 2 bipolar disorder, from a psychiatric standpoint, have extreme episodes of mania, so recurrent episodes of mania. Type 2 has a component that's also associated with big recurrent episodes of depressive episodes as well. So mania with both type 1 and type 2, which, to be clear, mania is going to be an acute heightened state of extreme energy or heightened senses and things like that. We've all met somebody we hear the term manic a lot, but it's essentially somebody that's perpetually energetic, perpetually high strung. Sometimes they come off as almost excessively positive, which sounds weird, but
a little bit of mania is good. Too much of it.
Little bit of mania, so the type 1 and type 2 bipolar disorder both have the mania component. Just the type 2 has a more advanced depressive component too, outside of the episodes of mania.
Wow. Okay. So, I didn't know that. I'm glad I know that now. Yeah. And what are some common treatments for bipolar disorder?
So the treatments for bipolar disorder, unfortunately, in traditional medical setting, are not much different than a lot of psychological diseases. I mean, the drug choice is different, but first-line intervention is, traditionally speaking, pharmacotherapy, drug intervention. Now, when I say it's not different from other psychiatric disorders, I don't mean that the drugs aren't different, but I mean that the first-line intervention is generally drug interaction,
Right.
Whereas you look at something like chronic depression or anxiety, they may defer more to things like SSRIs, your sertralines, Lexapros, things like that. With bipolar disorder, they tend to get more advanced into pharmacotherapy. Now you're getting more into second-gen antipsychotics, off-label use of seizure drugs and things like that. So, but first-line intervention generally is pharmacologic intervention, right?
Yeah.
And of course, hopefully they're doing some sort of actual counseling or therapy with it. But most of the time, it's real heavy-hitting pharmacotherapy.
Yeah, and I'm sure we know people because as I sit here and look at this and I see lithium, and I think to my personal family members, especially somebody close to me, he was put on lithium. And I mean, when we talk about the function that these medications have on people, you're talking about changing the brain chemistry. Right? And I watched that happen to him. Right? Change the brain chemistry. Change him overall, period.
Yeah. They can become like a different human being.
Yeah.
They do. And what's tough with it, and I always like to be clear, I'm not somebody that's like stringently opposed to all psychiatric intervention. I certainly don't feel that way. And I think in some small instances, there are some cases where medication intervention is probably an absolute necessity for maintenance of quality of life, or even for the potential of, if somebody's at risk to themselves or things like that. But all three of us know the frequency that we see patients come in on psychoactive drugs has gone up so much in the last 10 or 15 years since I got in the medical field. It's crazy. They seem to be more commonly prescribed for less severe cases or in situational basis, and honestly prescribed by people that it's not their specialty. And again, just like we talk about what we do as a specialty, I think psychiatry is a specialty too, to the point where, I'm not going to speak to anybody about oncology. I'm not a
Right.
cancer specialist,
Right.
so I'm not going to speak to that. It seems odd where we see some of this pharmacologic prescribing coming out of. We see people on SSRIs all the time. But the problem that you have with that is with drug therapy is there's not a lot of objective diagnostics that go on behind the prescribing. Right. So for us, when we're putting somebody on a medication or supplements,
the whole thing's very subjective.
Right. So when we're going through prescribing, whether it be we're putting somebody on prescription medication or we're even using supplements or even prescribing dietary intervention, there's objective data that we've gathered that have guided that treatment decision-making process where we feel confident we're making the right choice.
Just to be clear so people understand, so objective would be like
how you feel.
Test.
Or objective, yeah.
Like real testing, the test doesn't lie, where subjective is more...
How do you feel, what's going on, type of thing. And most, sorry, I messed that up for a second. Yeah,
I
blew it. But yeah, sorry, my brain goes faster than my mouth does sometimes. But yeah, so we're treating based on objective data coupled with symptoms. A lot of centrally active drug prescribing, and I'll say this as a caveat, this is something that's obviously very personal to me because I was on psychoactive medications from 12 to 35 and do have some family history of psychiatric problems. So this is something that I've seen, I have personal experience with and have experienced some of the benefit, but also a lot of the pitfalls. But anyway, back to the original point, you have somebody come in, you do an evaluation, you assess what their subjective symptoms are, and you make an educated guess at what the psychological disorder is based on those symptoms. Now, you may have drugs like SSRIs that work on serotonin, some that work on serotonin and norepinephrine, some that work at dopamine and norepinephrine, some that have sedative-like effects, MOAI inhibitors that influence a more broad spectrum of neurotransmitter function. So they're all neurochemically active and they're all influencing, obviously, that whole cascade of different neurochemicals that influence how we feel, those neurotransmitters. But, there's not objective data gathering as far as, is this actually the problem? We look at something like organic acids or a Dutch test that may infer there's there's an insufficiency in the conversion of L-dopa to dopamine or tryptophan to serotonin, but that's not being done. So you look at anxiety and depression and say, well, I think that they have chronic mild depression. First line intervention is an SSRI, right? Which those have a myriad of side effects. Or I think that they have bipolar disorder, okay? And bipolar disorder, we're going to use one of these second-gen antipsychotics, plus we're going to use Lamictal or something off-label for mood stabilization. Well, the problem is that's still a guess, right? Now, there is testing that's called gene site testing, right, that will actually look at a genetic profile in a patient's propensity to respond to different drugs of different classes. So it may say, in the SSRI drug class, you're going to do really good with this drug, maybe not so good with this drug. This one may have a high side effect profile based on your genetic profile, okay? So you would think, oh, well, that tells me what drugs to use. But it doesn't, because whether or not the drug choice is right is still predicated on whether or not the psychological diagnosis was correct, right? So it doesn't tell us, yes, this is the right drug. It just tells us, if the diagnosis is correct, this is the drug that may have the lowest side effect profile. So even with the testing that is done, it's still a gamble, right? And unfortunately, with any psychiatric medication, because you are messing with brain chemistry, you can be on the wrong drug, and you're going to have to be on it for a while because you have to titrate the dose up and titrate the dose down. So one of the things that I personally experienced as a teenager and then in my 20s is, I went through 3, 4, 5 different medications before we found one that I felt, subjectively benefited me. But there was a year and a half to 2 years in there of me being on the wrong drug that made things worse. Right?
That's scary.
So when you think of somebody that's going to be put on a psychoactive medication, this is somebody, if they're taking that step, they're already in crisis.
Right.
And we need to understand that, these medications, we're not taking an Advil, right? You're changing, which even, that's a loaded statement too, but you're changing brain chemistry. And one of the issues that you may run into is you may acutely potentiate their symptoms they're already having, right? So, and when we get into bipolar disorder, which is a way more advanced psychological condition, it's rarely ever have I seen that it's, hey, this drug and now you're better, And that's with a lot of psychiatric intervention. It's, hey, I'm going to give you this SSRI, for anxiety, depression. Well, it's mitigated that, but now I'm emotional, right? And I don't feel depressed or happy. I feel nothing. And also, now I can't get an erection or ejaculate.
Right.
Okay, well, what we'll do as a rescue to that is now we're going to give you Wellbutrin because we're going to push your dopamine up, and that will enhance sexual excitation and feelings of pleasure. So now I'm taking a drug to combat a drug.
So now you're really starting to mess the brain chemistry all over the board.
Right. So and again, like I said, I'm not anti-psychiatric intervention, but I think the rate that those medications are prescribed, and that's across all things, is way more commonplace and way more. I don't think people understand, necessarily, like this isn't a simple medication you're taking,
Right.
and it's not something that should be so casually dispensed.
Right.
Well, people don't know.
Yeah.
And people, now in today's world, when people feel some type of way,
Yeah.
they want help so bad, the first thing they do is schedule an appointment with a doctor.
Right.
And they're going to listen to whatever the doctor says.
Right.
Because that's just what we do. And we want to count on our doctor. And so it's funny because some of these, you mentioned some of the drug line there, prescriptions and stuff. And it takes me back to a few places too.
Yeah.
And I mean, they're easily prescribed.
Yeah.
Just 5 minutes in the door. And then you already have, typically 2 prescriptions of something.
Yeah.
And then take these and we'll see you in 30 days. But really, I mean, with some people, you start to feel real different quickly.
You do feel very different quickly. And unfortunately, I, for example, was on an SNRI for many years. I've been on Seroquel, I've been on Lamictal, I was on Effexor. And some of the things we've done through our practice that's remedied has eliminated the necessity for me to be on centrally active medications, and I feel much, much better because of it. But I did spend a lot of years on those. But, sometimes stuff quits working, and they say, well, let's try this one instead. Let's try a different class. And I went through a period after being on pharmacologic intervention for 15 years where I had my medication switched to Lexapro, citalopram, which is a super common drug. And it threw me for a loop. I mean, it exacerbated manic type symptoms. I felt like I was less rational, less under control. I had less enjoyment in my life. I felt quicker to anger. I didn't sleep well. I felt really,
how long did that take to
really
kick in?
bad. It was within a week or two of being on it. And, obviously me having some experience, understood, hey, this is drug acclimation. This is acclimation that's going to get better. And I kept taking it and kept taking it and kept taking it. And then we bumped the dose. And I went for months, and it was just, I kept getting worse. And it's funny, it wasn't until, and then when I finally titrated off that medication and got some clarity, then you go back and reevaluate the status of your mental and emotional well-being and where it was in the previous 6 months. And it's a little alarming. You said, oh gosh, I was not like,
It was a hot mess.
I was a hot mess. I was not in a good place. And,
Yeah.
I knew I wasn't good back then, but, retroactively evaluating myself, I was even worse than I thought I was. So.
Well, a lot of people, unfortunately, don't think for themselves and just do whatever the doctor says. And how many people just say, oh, the doctor said I need to take it, I need to take it, and that's sad because if you're not, you have to be introspective to yourself and how are you actually feeling, how are you doing? And if not, voice your opinion. And doctors are busy, Average doctor visit in the U.S. is 6 or 7 minutes. So if you don't voice your opinion, trust me, your GP is not going to remember.
No.
You're off the radar. So,
and again, me, even knowing what I know about these medications, had that pitfall of, Joe, you know what this is. It's acclimation. Just stay on it, push through. Eventually it's going to start working. It just never did. And I'll be honest with you, I certainly won't name anybody, but the doctor that I was working with at the time, that was a psychiatrist, I have a tremendous amount of respect for her. I think she's a great doctor. I think she's well-intentioned. I find her to be quite brilliant, and I really enjoyed anything I did with her at that time. So this isn't an attack on her as a physician. I actually have a tremendous amount of respect for her. Mm-hmm. She was doing what medically is trained to do. But again, it's still educated guessing. Yeah. So.
Wow. I'm glad that you shared that with us, honestly. And so I want to bring up, now we're going to tie in, actually we're going to talk about what insulin resistance is. But first, so apparently Dr. Cindy Calkin found a correlation between insulin resistance and bipolar disorder, which I said that's very interesting. And so tell us what insulin resistance is.
So insulin resistance, if we wanted, I'll try to give the abbreviated version because so many people in America have it and they have no idea that they have it. Insulin is one of the primary hormones that influences glucose metabolism. And that list of things that influence glucose metabolism is a very long list. But to the core, we'll pick two, insulin and glucagon. Insulin pulls sugar out of the blood into tissue. Glucagon pulls sugar out of the tissue into the blood, right? So those are the two big immediate mediators of glucose. Now there's other things like cortisol and testosterone and growth hormone that influence, but those directly mediate blood sugar values. So insulin in a nutshell's whole job, blood sugar goes up, it reaches threshold that we can't maintain that value out or isn't good for us to maintain. Pancreas releases insulin. Insulin hits its target tissues and basically says, open up, let us put glucose in you so we can get out of the blood and stabilize our glucose, okay? This is a broad statement, but generally speaking, if we don't dispose of glucose immediately, we're going to have three primary target sites for glucose storage, right? And that's as glycogen is the muscle cell, glycogen in the muscle cell, glucose in the liver, or a process called de novo lipogenesis, which is essentially the diversion of glucose into adipose tissue fat cells, right? And how we develop insulin resistance is essentially this, okay? Whatever sugar does, insulin has to do in a compensatory manner. So if we get a big spike in sugar, we have to get a big spike in insulin, right? Because it has to be a compensatory response. Well, what happens over the course of years, let's say with poor dietary choices, certainly there's genetic influences to this and other mediating factors like other endocrine dysfunction. But simplistically, we'll just talk about dietary choices. Let's say you have somebody that has a diet that's high in refined sugar and refined carbohydrates. They drink a lot of pop, they eat a lot of candy, they eat a lot of sweets. What we're going to see as far as a acclimation is we'll get transient glucose spikes, we'll get a big insulin spike, and over years we'll see that glucose will still continue to fall initially. Insulin will fall ever so slightly, but it never returns to that real significant pre-meal value. So, you know, on paper, you almost don't see sugar issues with a lot of these patients initially. What you would see if you tracked it, let's say, over 10 years is fasting glucose would be fine. A1C may increase slightly, but it'll stay within normal limits. But fasting insulin would creep up. So let's say 10 years ago, your fasting insulin was 5, and now maybe your fasting insulin's 40. And the reason that becomes an issue, and to be fasting, it means, you know, when your glucose is stable, you haven't eaten, and there's nothing going on from a blood sugar standpoint that facilitates insulin to be doing anything. So insulin's just kind of higher all the time.
Right.
Okay. Now, the reason that's an issue is insulin, like all other hormones, communicate with your cells via receptor sites. Okay. Little places, essentially, they're going to attach themselves to, and they facilitate whatever mechanism or change in the cell that they're supposed to stimulate. Okay. The insulin receptors on the muscle and liver with overexposure essentially become desensitized and unresponsive. Okay. So essentially, insulin resistance, in a nutshell, is a loss of sensitivity at those receptor sites where we no longer get the appropriate response to insulin, right? Which right out of the gates, it's going to do, well, you're going to starve the muscle and liver because you're not getting glucose delivery, which one makes you feel like garbage. Two, we're accelerating uptake of glucose from a fat storage standpoint, right? But again, on paper, a lot of these people won't show up as having sugar issues because the glucose is getting out of the blood, just going the wrong place. Now, the other issue we see with insulin resistance too is it also tends to significantly upregulate the storage of what's called visceral fat. And we know that visceral fat is really a direct indicator of advancing metabolic disease. Okay, and to be clear, visceral fat, that's the deep fat underneath the abdominal muscle wall. Kind of the extreme example of this is we all have the family friend or uncle who's got like the giant beer gut, but it's hard as a rock. Sometimes we joke about it. That somebody's got a lot of visceral adiposity. And the reason that's so dangerous is we know that it doesn't just store calories like subcutaneous fat. It almost influences like another organ or gland. It changes the function of other tissues. And one of the very first things it hits is the liver. Okay. And the liver is a big piece of fat metabolism. Liver helps us cleave free fatty acids or triglycerides into free fatty acids, which is ultimately the metabolizable form of fat. We know the hepatic processing of an insulin resistance person that essentially is going to work backwards. We'll start to synthesize triglycerides out of free fatty acids, basically reversing the process. And then those triglycerides may stay in the blood, or they're going to get used to synthesize LDL cholesterol, right? So then our cholesterol is going to go up, which is why we've seen, only 10% of cholesterol in the blood comes from eating it. The other 90% is synthesized via the liver, which is why cutting cholesterol out of your diet's never dropped anybody's cholesterol significantly,
Yeah.
So essentially that metabolic cascade all starts because of poor receptor response to insulin. And that's what insulin resistance is.
Okay. Yeah.
Sorry, that was probably a long-worded answer.
It was, but
Yeah.
I think people need to know that.
You hear that terminology all the time. It must be what
Yeah.
it means.
A lot of people know, or they'll tell me
Yeah.
that they're insulin resistant, but they don't know how or the why. And so
Right.
you just went through that. So
And-
you might have to rewind that to listen again. I know I'm going to, but that's a great.
And that's what we always tell people at the office, and I have for a long time, insulin resistance is the Pandora's box of disease.
Yeah.
Because once that starts, the downstream cascade of everything that changes physiologically is a nightmare,
Right.
right?
Yeah.
So,
Yeah, we know that.
and again, you can be insulin resistant for 10, 15, 20 years before anything ever shows up on paper as a blood sugar problem.
Yeah.
So,
Yeah. We definitely know that from experience. 100%. Wow. And so, how are bipolar disorder and insulin resistance, like why are they related? Like tell us.
So the article is very interesting, and one of the things that she does mention, and this really ties insulin resistance and functional medicine together, is the precursor step to this is genetic and epigenetic factors that make somebody more prone to psychological disorders with high sensitivity to stress reactivity. Okay, so you have those genetic epigenetic factors that predispose you to being sensitive to stress. You have a heightened HPA axis response, hypothalamic pituitary axis, and then a state of chronic hypercortisolemia, where your cortisol is high all the time. Well, what do we know that cortisol does to blood sugar? Right?
Yep.
Raises sugar, induces insulin resistance, stops fat metabolism, exacerbates an insulin resistance profile. No, insulin resistance, like most metabolic diseases, is a pro-inflammatory condition. It's inflammatory everywhere. It's inflammatory to the vascular system. But essentially, the pro-inflammatory response to that insulin resistance profile, coupled with chronically high levels, stimulates an inflammatory insulin response. What that inflammatory insulin response does, and that immune response from the hypercortisolemia does, is it allows all of these very pro-inflammatory cytokines, that'd be TNF alpha, interleukin 1 beta, interleukin 6, a myriad of them, to cross the blood-brain barrier, right? And it's that pro-inflammatory response and essentially the crossing of those pro-inflammatory proteins into the blood-brain barrier that tends to exacerbate the bipolar disorder.
Wow.
Right.
There's always inflammation on the brain, or
right. Yeah. It's crossing. It's the crossing of those pro-inflammatory cytokines across the blood-brain barrier, and then having immediate neurologic effects that potentiates the symptoms of bipolar disorder, essentially from neural inflammation. Right.
Wow. Yeah.
And again, that's a combination of the insulin resistance profile coupled with the inflammatory immune response dictated by the adrenal glands.
Yeah, and it says that her study combined with the current protocol of metformin, and I'm sure a lot of people have heard of metformin, right? So we are all very aware of metformin. And if you don't know what metformin is, Joe, briefly, what's metformin?
So metformin is traditionally a diabetic agent. It's something that's gotten used more readily from an anti-aging perspective or an early intervention. But essentially the biggest benefit metformin is it's going to agonize the insulin receptors on the periphery of the muscle and liver cells. So when we talk about insulin resistance, we talk about the loss of response to that hormone. It's trying to remedy that process. So it's mediating glucose metabolism and enhancing insulin sensitivity and response. Which, that study was specifically done on metformin, which, obviously you're going to pick a drug and stick with it. But, if you read further into it, it certainly extrapolates out that any drug that's going to positively influence insulin sensitivity and response would have a relatively equivalent benefit, even looking at like the GLP-1 agonist and things like that. In fact, she does mention, and she lays out a really beautiful graph to explain this whole cascade and how it starts as far as the inflammatory process. And when she looks at states of disease progression, she does list metformin and the GLP-1s within that treatment protocol. Right. So,
wow. Yeah, that's great. I love that. Yeah, it says that basically she even did some MRI scans of the brains and how the brain changed.
Right.
So, that's great. And I talk to people, and I know Dr. Buzz does too, and you do too. And we tell people, when you have these symptoms of feeling, I don't say bipolar, right? But I do say mood swings or maybe like anger or any type of mood issues, right? I always tell them, like, functional medicine is where I'd go to.
Yeah.
That's where I'd start, right? But obviously you could do different things. And now we know that insulin's a big one.
Well, and it is interesting when you go back to functional medicine. And of course, we're all very aware, and we've talked about many times, the influence of cortisol on mood, general sense of well-being, the influence of the HPA axis on other systemic issues, the influence of gut on cognitive function. What's interesting, and of course she does identify in this study, she's not negating that there are genetic and epigenetic factors that influences somebody's propensity to develop bipolar, right?
Right.
She's not exclusively blaming bipolar disorder on insulin resistance at all. So I don't want to mischaracterize her study. She is identifying, hey, listen, we know there's people that are prone to this, but
This is definitely an aggravating factor.
but the downstream effect, the two big things that she identifies was potentiation of that neurological or that psychological disease state by HPA axis dysfunction, hypercortisolemia, and the negative metabolic effects of insulin resistance.
Yeah.
So, yeah, well, there is definitely propensity to it when we're looking at direct intervention, and functional medicine really pulls this full circle. And we talked about what's first line intervention: drugs, drugs, pharmacotherapy. What's not traditional intervention for psychological disease in most practices, right? Functional medicine, HPA axis management, more advanced techniques for
That's
stress
really the
management,
root cause.
lifestyle modification, and
Right.
metabolic disease intervention, right? So even if you're somebody who, again, I would say this, not saying that psychologic or pharmacologic intervention for psychiatric disorders is never right. There are certainly cases where it's necessary. But if you have somebody right now who says, oh, well, I'm on these, they helped, and now they don't help anymore, there's a whole other piece that
Right.
generally isn't going to get addressed. And, you know, as you reference all the time, you know, the normal doctor visit is 6 to 7 minutes, okay? A counseling session may be 30 or 45 minutes. You know as well as I do, when we do functional medicine, when we're doing adrenal care and gut correction, over the course of 5 to 6 months, I may be with somebody either on the phone or in person 6, 7, 10 hours.
Yeah, it's a lot of
You
work.
know,
Right.
it's a lot of work.
But
and
everyone's different. There's no cookie cutters, the thing,
Right.
right? There's no cookie cutter.
yeah.
Right.
We're
Yep.
just different.
You have some patients that take to it super quick, where, you know, 6 months I may talk to them 3 times for 30 minutes and everything's great. But you have some patients where, you know, it's a lot.
It's a lot of work. It's a lot of dialing in.
It's a lot of work. It's a lot of work on the provider's part. It's a lot of work on the office part. It's a lot of work on the patient's part.
Right.
Right.
Definitely the patient.
It's a lot
For
of work on
sure.
the patient's part. But it's,
I think everyone could benefit, no matter what your psychological disorder, with doing like a basic adrenal test, a gut test, because you know your gut is where your serotonin and dopamine, a lot of it's produced,
right.
and most of the drug interactions are to mess with those levels. Where you can kind of fix those, or at least improve upon those by fixing your gut.
Yeah.
But you got to do your adrenals with it because they go hand in hand. But
Yeah.
And I also think the organic acids test is really cool because it does show your neurotransmitters.
Yeah,
Right?
yeah, it's super interesting as well. And we see a lot of people with adrenal fatigue where they have their homophantalate's low. So we know, like, somewhere in that L-dopa to dopamine conversion, there's a break,
just somewhere,
right? So say, hey, instead of going straight to, you know, something that works on dopamine, you know, instead of going to a dopamine agonist or something like that,
let's try to fix your pathway.
let's try to see if we can supplement with high dose of tyrosine or something and do adrenal correction and see if we can remedy that value.
Yeah.
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 Wow.
I think especially I like it a lot for especially younger, because a lot of kids are getting put on these meds at really young ages, and
Yes.
you know, as a parent, if you know, why not come test your kid? I mean, we test kids. I mean, a lot of kids are messed up.
So kids are very messed up, right?
I think it's, you know, I think society, and they never get a break. They're on their phones all the time, and they're playing sports year round, and
They're eating all that crap food
it's just different.
sometimes.
Like kids don't, you know, you don't ever see kids just like riding bikes and hanging outside anymore. Like they're constantly under the gun,
Yeah.
and I think that's a lot to do with it.
Yeah,
Yeah.
it is. They're constantly under gun. They're under the phone, and I've talked about it before. Obviously, we all have kids. You know, your boys are, you know, right out of high school, and then not long out of high school. You know, between Jamie and I, we have 11, 17, and 21. It used to be in high school you had to worry about kids being pricks, but it was just the ones you went to school with. Now with
Right.
phones and social media, you get worried about the perpetual judgment and evaluation.
They're getting bombarded. The kids are on the
Yeah.
phone from the moment they wake up, midday, when they go to bed. They're on that stupid phone, right?
Yeah, on the phone, on video games, on it's really, you know, it's weird. I've talked to my daughter about it a lot because she's going right into middle school, and
That's the age.
I told her, I said, you know, middle school is a weird pathology. I said, because it's like everybody's gangly, everybody's awkward, everybody's going through puberty at different rates. So this is when you're going to grow weird and have acne and weird. And kids all seem to really desire acceptance and inclusion, but also simultaneously lack any capacity for empathy whatsoever. Mm-hmm. It's like, which is a really weird thing. Yeah. So, you couple that with, being on phones all the time, being on video games, sleep quality is poor, physical activity is less, food is garbage.
Yep.
Yeah.
My oldest sister lives in Spain, and she's been there for years. She's got 3 beautiful kids over there, my nieces and nephews. And they deal with normal kid stuff, right? Because kids are kids.
Right.
But, there's a lot of foods over there that they can't get that they sell here. Spain won't let it in. Yeah. There's different quality control over there. Even things that they do get there in the States, the ingredient list is different.
That's what happened when we went to Panama and Colombia. Like the food at the stores is
everything
amazing.
tastes so good.
Amazing. Like,
because it's so different.
Well, and one of the things that when I talk to my sister that you don't have extraordinarily high rates of childhood obesity, and you don't have half of kids under 18 on some sort of psychoactive intervention with medication.
Right. Yeah.
Right?
Right.
Sad.
Yeah.
It is.
But there's alternatives out there, So
there is. Right.
Kid, how many kids just they eat the foods they eat make them act that way?
Yeah.
And they go to the doctor, and instead of changing the diet, they put them on drugs.
Yeah. Right.
It's crazy.
Yeah, it's like, what's your kid eating? Yeah. Well, they're eating processed foods, fast foods, not whole foods.
Yeah, Pop-Tart.
I mean, come on.
Cereal, whatever, garbage for breakfast.
Yeah, Pop-Tart and a Dr. Pepper for breakfast, and then my snack was a Nutty Buddy bar. And
yep.
And kids, kids like to eat stuff that tastes good, and I deal with that with my daughter too. I have to check her. We go out to dinner, we go out to this and that. I'm like,
anything in moderation is fine.
Yeah,
right?
but
I'm not saying that your kid can have pizza or something, but
right.
Like,
yeah, but it's
if
little
they're living off that stuff.
We have some diet pop in the house and stuff like that. But my daughter's 11, so I always have her. Hey, before you go get a pop out of the fridge, you need to ask me first, because I know that if I don't check it, you're gonna drink 4 different Dr. Peppers today, and you're gonna have like a thimble full of water.
Yeah.
Or she'll go down and want to grab a snack. Hey, don't go eat a pack of fruit snacks, eat an apple, or don't go eat anything right now because we're getting ready to go out to dinner.
Right.
Yeah.
And I don't want you to fill up on garbage and then let's go out and actually get something of nutrition. You eat 3 bites of it and be full.
Right. Right.
But it's, so.
Wow. Well, I really enjoyed this episode. A lot of good stuff here for people. So if you're listening and you have any questions of what we discussed today, you can always feel free to ask. You can also always call the clinic. You can come see us at the clinic, Buckeye Physical Medicine and Rehab and Anti-Aging. But we would definitely love to hear what you have to say, and maybe we can help you. Joe, thank you so much for being on today's show.
Thank you for having me.
And I know we'll be seeing you again. All right. Thanks.